Hello all. In this session, we'll further learn about the essentials of how to assess diagnostic stewardship program. Let us understand about the implementation of this program. Training for all professionals at each stage is vital. Everyone should be aware of the diagnostic workflow and their respective roles and responsibilities, and are able to perform the activities appropriately. Local guidelines and SOPs needs to be developed and adapted by the staff and disseminated to tailored training. What are the essentials of the education provider? Yeah. Diagnostic methodologies should be used, indication for testing in the institution, available alternative testing, advantages and limitations of the testing should be specified, associated cost, the turnaround time, presentation of report, and guidance on interpretation. What are the specific areas of training? It includes clinical staff, the surveillance staff, and laboratory staff. For the clinical staff, it is the case finding and relevant diagnostic tests, then interpretation and communication with the microbiologist. For the clinical staff, it is criteria and indication for specimen collection, providing request forms, transportation, collection, and storage at the site before transport, and interpretation of the lab results. While for the lab staff, it is SOPs for pathogen detection and for bacterial species identification and sensory testing, and effective communication with the clinical staff. So these are the specified areas of training. What's the role of National Reference Laboratory? It serves as a resource and coordination point for lab expertise. Developing, maintaining, and sharing the reference materials for good lab practice comes under the responsibility of the National Reference Lab. What are the external quality assurance programs? These are the trainings in the data management at the sites as a component of the diagnostic feedback process. What are the organization aspects of diagnostic stewardship? This includes SWOT analysis or situation analysis, an assessment of the resources and needs assessment, then developing a realistic plan for the implementation of the program, then prioritization according to the healthcare settings on the basis of the resources available for the diagnostic stewardship program. So let's understand in detail what do you understand by SWOT analysis, that is strength, weakness, opportunities, challenges analysis. It includes the review of the existing SOPs, guidelines, resources, clinical lab and surveillance capacity, including quality management and other systems, then barrier constraint analysis and reimbursement of the diagnostic testings and others, and trainings and others. Now, what do you understand by prospective audit with interventions and feedback? The audit is done to collect the data, the quantity of prescribing, the quality of the prescribing, do guidelines exist for the prophylaxis and treatment, what is the compliance with the guidelines for prophylaxis and treatment, is there a pre-authorization and review process. Then analysis, after collection of data, then there is an analysis of data, then there is feedback is given to the stakeholders, investigate as necessary the new interventions. Then reporting information to the staff on improving antibiotic usage and resistance is essential. What do we report? What is implies? Does your stewardship program shares facility-specific reports on antibiotic usage or test reports with prescribers? Has a current antibiogram been distributed to the stakeholders? Do prescribers ever receive personalized communication about how they can improve their antibiotic prescribing or testing, diagnostic testing? What are the strategies and the methods are employed? This should be an ongoing systematic collection and analysis of healthcare data, essential to planning, implementation, and evaluation of public health practices. What are the strategies? The strategies are active versus passive, clinical versus lab, and retrospective versus prospective. The methods employed are hospital-wide, limited period, prevalence-based, and targeted-based. Post-implementation of the activities, this will be it includes showcase the work, that is number of patients, number of interventions, and the big picture vision. Start with the cost burden and the hospital of what you have improved. Keep the documentation as consistent as possible, make it as a deal, and get it in front of as many stakeholders as possible. Stay focused, prepare how to material, and deliver the workshops for the program. Keep the team and lab staff engaged and friendly. Now, what are the testing changes that we do? Plan a change, do test the change, study, review the test, and in action refine the change. So, plan a change, test the change, review the test, and refine the change. Linking the PDSS test, that is a plan, do, study, act, test cycles. Start small, think ahead, and don't wait to begin. Establish a culture of cultures. Have a hospital antibiogram, customize antibiotic policy according to antibiogram, surgical prophylaxis based on the antibiogram, the protocol-driven treatment guidelines, and loading dose in severe infections, de-escalation strategies, IV to oral switch interventions with a view to early discharge, and duration should be less than 7 days or less than 14 days accordingly. Then monitor and evaluate the change. Higher score attainment after initial audit may be attributable to better record keeping. Evaluate it over time. Maintain and reinforce the change. What are the implementing changes? Identify the barriers. The fear, the lack of understanding, the low morale, the poor communication, individual culture, doubt of outcome, and consensus not gained. Then remove these barriers. Make improvement and remove the barriers. That is lack of organized MRD, incomplete record, poor quality maintenance, ignorance of value of medical audit by hospital staff, suppression of the facts and others. If you haven't met your standard after the second cycle, then what are your options? Make further changes, decide if your standard may in fact be unachievable, and lower it accordingly. This is what a pure PD plan to check study adjust cycle looks like. We will speak in details in this through this slide. First, plan. Map the possible enablers or champions and barriers in the unit. Often managers and champions commitment to the change. Prepare to talk about the resistance, the usage of antibiotics, and what can be done for the program. Present the AMR program challenges and discuss what we can do. Set smart goals. Decide on the interventions, how to implement, and how to measure change. Perform the AMS interventions and do the measurements. Analyze the measures, what they do show, evaluate the interventions and their implementation. Prepare to discuss the results. Review the resources used and cost and determine whether they are making savings. Discuss the results, agree on any adjustment, and follow up with the continuous improvement cycle. That is plan, do, study, adjust. So the take home till now from the session is that treat the patient with effective empirical antimicrobial treatment while maintaining the efficacy of our antimicrobials and keep resistance to a minimum. A fine balance should exist between the overuse to prevent overuse or misuse in the fight against antimicrobial resistance. Underuse is immoral and not to appropriate treat. Responsibility to current and future patients should include consider that antibiotics are a limited resource. What's the food for thought? The thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbed to infection with the penicillin organism. This is what was quoted by Sir Alexander Fleming and rightly said. So to summarize again with the principles and some few critical concepts of this steward program. To summarize, the antimicrobial stewardship means it's a pharmacy-centric or antibiotic-centric, wherein we say that use the right drug at the right time at the right dose for the right duration. But in the diagnostic stewardship, we obtain the right test in the right patient in order to use the right drug at the right time at the right dose for the right duration. What should the syndromic approach implies? Getting actionable lab results into the hands of the healthcare providers faster and can lead to better patient management decisions, including diagnosis and treatment decisions. Syndromic testing can empower the diagnostic stewards to choose the right test at the right time. When patient present with infectious diseases with non-specific signs and symptoms, then the optimization of the diagnosis should be done to avoid unnecessary testings that comes with the individual and serial testings. Multiplex nucleic acid amplification test provides pathogen-specific results in about an hour, which can facilitate the targeted approach rather than a broad spectrum approach. But it should be used rationally. Collection of the pathogen-specific data that can help the healthcare facilities make the data-driven diagnostic plan. Choosing the correct test. Now, as it's been repeated from the beginning of the session, choosing the correct test is important. What does this imply? Is the test indicated? Is the timing of the test appropriate? What's the turnaround time? It should be lesser. Will the test result influence the care of the patient? Are criteria available for interpretation? Which specimen to be corrected? How to correct storage and transport of the specimen? Let's remember the Cochrane aphorism. Before ordering test, what will you do if it is positive or negative is very important to consider. If both the answers are same, then don't do the test. Now let's understand the examination cycle. Examination cycle we have three components: pre-analytical, analytical, and post-analytical. In the pre-analytical, we have to check. Our checklist should include that properly filled up request forms are there. Are the correct containers used? Correct packaging used? Adequate amount of the specimen is used, and transport is done appropriately. And the analytical domain includes there is a following of standard treatment and guidelines, quality control measures, all methods, equipment, and procedures are in place, and they are practical, achievable, and affordable, and biosafety measures have been followed. While post-analytical measures include reporting the formats with reference ranges, selective reporting, of antibiotic susceptibility, interpretation of the results, differentiating it from colonization, infection, and contamination, and there should be good communication, documentation, and retention disposal of specimens. So that was about the details of the examination cycles. We should do cultures before antimicrobes are prescribed because it improves the chances of identifying a microorganism. Administration of antimicrobials before cultures may decrease the culture yield. It is more difficult to de-escalate therapy without cultures. Rapid diagnostic tests such as Gram-Chin is done to determine the therapeutic choices or empirical therapy. Do not delay the therapy for such results. Baseline inflammatory markers such as WBC or CRP, procalcitonin, and the response to antibiotic therapy along with clinical parameters should be considered. Absence of both elevated baseline the WCC and antibiotic related decrease in CRP can exclude bacterial infection and facilitate the AMS efforts. Procalcitonin can discriminate bacterial from viral infection, but has not been systematically compared between bacterial pneumonia and COVID-19. Increased PT, AST, CKMB, bilirubin, BUN, creatinine, and altogether indicate multi-system damage, that is secondary bacteremia. How can we fight dual pandemic COVID-19 and AMR? Increased clinical competence among healthcare workers who targeted training. As said before, eyes can see what the mind doesn't know. Knowledge is very important. Education is very important. Able to identify the signs and symptoms, eliminate unnecessary antibiotics, do the correct testings, implementing strict infection control measures are important. Remember the golden rules of antimicrobial prescribing. In the mnemonic, mind me, where M stands for microbiology guided therapy, I stand for indication should be evidence based, N stands for the narrow spectrum required, D stands for the dosage appropriate, M stands for again minimize duration of therapy, and E to ensure monotherapy. So remember this mnemonic for as the golden rules of antimicrobial prescribing. Strategies to control antibiotic usage. There are front-end and back-end strategies. Front-end include guidelines, antibiotic policy, antibiogram, guidelines for specimen collection, storage, transport, formulary restriction, pre-authorization. While the back-end strategies include audit and feedback to the stakeholders, the team review, antimicrobial review, which include drug monitoring, sensitive results monitoring, adverse drug reactions, and others. It should be borne in mind that undertreating does not tend to be an issue. Overtreating with extensions of antimicrobials are not uncommon. Recommended duration should be followed and increased use of. The key components of the stewardship program includes a dedicated resources should be allocated, a multidisciplinary team should be in place, governance within the hospital's quality improvement should ensure the quality of and safety of patient care. There should be clear line of accountability between the different stakeholders. The next steps include understand, assess, demonstrate. There should be leadership role, then training and research. In access, we mean that there should be measures to assess the diagnostic program. In understand, we mean that the drivers should be in place to motivate and to the healthcare providers to invest in diagnostics. Demonstration implies demonstrating the benefits of improved testing to healthcare facilities. Leadership role to also ensure the resources are available and to support the program. Training resources should be available and should be done on a continual basis. This ongoing research should be there in place to develop and implement best practices for the program. Now, how to combat the AMR? There are different strategies. There are various strategies. The most important is hand hygiene, then environmental hygiene, equally important as hand hygiene, then screening and cohorting of the patients for infections and for infectious diseases, then surveillance of the patient, integrated stewardship, that is diagnostic stewardship, infection control stewardship, and antimicrobial stewardship, then adherence to the guidelines and safety culture. So these are the different strategies that should be used to combat the AMR. Through the epidemics of antibiotics, get smart and know when not to prescribe the antibiotics. Antibiotics are uniquely societal drugs because individual use affects others in the community and environment. Be a champion in preventing and managing infections. Clinicians with knowledge and awareness towards AMS are play a key role. Clinicians can promote the culture of for antimicrobial stewardship and diagnostic and inpatient. Document and share the success stories or best practice. Spread the word, educate the masses through social media, and engage, educate, and empower. Consumer education is very important. As you can see from the slide, provide patient education about antimicrobials, how to tackle the AMR, and it include differences between bacterial and viral infection, what is AMR, and other such factors. That's all from this session on antimicrobial prescribing, part of diagnostic stewardship program. Thanks all of you for your kind attention. Thank you.